Thank you very much. I appreciate that. Mr. Straley, you said that your daughter benefited from some Suboxone programs, which is buprenorphine. When she wasn't in the program, was she able to access Suboxone on the street? Do you know?
I do not know. I want to say no.
Okay. Because and I'm going to shift. I just wanted that as a fact point. Because in part of my district, I have a large rural district in Appalachia, and in part of my district, there's a number of Suboxone clinics. And what they have found is that it has become a street drug, that some of the patients who are there will take some of their dosage, and they will sell some of their dosage. And so, Dr. Crawford, have you seen any signs of that with your patients, where some of them may not be taking the full dosage? And what do you do to monitor if people are actually taking what you've prescribed them? And I assume you prescribe Suboxone because you mentioned buprenorphine.
Correct. Yes,
Yeah.
I do prescribe medications for the treatment of addiction. And so to more directly answer your question, yes, I have had patients who I suspected of diverting the medications that I prescribed. To be very clear, we take a harm reduction approach and a low barrier to access to care, but we're also not drug dealers, right? So we have to keep people safe, and we have to reduce their risk of harm. So in those circumstances, it's very clear from folks like the Drug Enforcement Agency that we couldn't continue that relationship. That was a clear mark that either this treatment is not effective for them, perhaps they may need a higher level of care, more support wrapped around them, and so we would not continue to go just as
If you picked it up, and I'm going to come back to that in a second.
Yeah.
Chief, have you seen any, and I'll use the doctor's term, diversion of Suboxone or buprenorphine in your community?
I personally have not.
Okay.
I do know that my brother's on Suboxone and that he has to go to a clinic to get his dosage. So I don't know if you take it all before you leave or if it's like, is it a pill you take a day? I don't know how it really works.
Right. So let's go back to the patients that are doing what they're supposed to do on this. And one of the worries that I have and why I worry about not having some limitation on how many patients that somebody has on buprenorphine is that they may not be paying as close attention as you are to whether or not there's a diversion. But let's go to the ones who aren't diverting. Do you ever get them off of the Suboxone? I mean, I know of one case in Maryland where a friend of mine's son had this issue, and he went to him and said, start weaning me off. And it took years, but he eventually got off and is doing great. But do you see that in your practice, or do we get them to just where they're stable and they continue to take the substitute opioid, Suboxone or buprenorphine?
Yeah, thank you for the question. And just to clarify, nothing we do in medicine is perfect, unfortunately.
Yeah.
And so,
Clearly, nothing we do in Congress is perfect. But you got a better batting average than we do. But I do appreciate that. But yeah.
Sure. And so, we accept that there's some risk, and we're always balancing the risk and the benefit analysis. And so you heard the majority of folks, 95% of people age 12 and older, depending on which data set you're looking at, don't have access to treatment or aren't engaged. And so that's a risk that we take, that perhaps some folks, a small minority, may be diverting. We don't want that to happen, and we act accordingly. We also know from the literature that the medication that is diverted is actually going the majority of the time to folks who don't have access. So it shouldn't happen that way, and we don't want it to happen that way. But that is where we think the majority of that medication is actually going. But to more directly answer your question, we're talking about a chronic medical disease, similar to other chronic medical diseases like type 2 diabetes or hypertension or high blood pressure. And these are things that folks have that they may take medications for the rest of their life, or these are things that they may have changes in their life or changes in their bodies that they may not need to take medication anymore. So I always counsel folks and treat my patients accordingly with, we're going to do what works right now. If that means we're going to take medication for the rest of our lives because that's what works and that's what keeps you alive and healthy, then that's great. If you feel like you want to taper, we can do so, but very slowly and for the right reasons.
And that's why I said it took years. You can't just do it overnight or you get into worse trouble. And I do appreciate that. But so you have had some patients who've tapered and gotten off of Suboxone or buprenorphine.
Yes.
Okay, good. Ms. Keller, I'm going to switch to you and slightly change subjects. Part of the Support Act had a section in it on drug monitoring. Those were sections that I advocated because, like the arm of Maryland, my district stretches out and goes from the Lynchburg, Roanoke area down to an area that's so far west, it's further west than Detroit, Michigan. And we touch a number of different states, and you can actually get in and get prescriptions in 5 different states. Maryland has a similar situation with its arm. And I'm just curious if you all have had success with the drug monitoring program. Does that seem to have stopped the illegal use of getting multiple prescriptions from different doctors in different states, or is it, or even in Maryland? Have you seen some success with that?
We have seen success with the prescription drug monitoring program. And where I'm
Great.
from, on the map where Maryland gets very small, we had the same issue. So
Yeah.
yes, it has been successful.
And so while everything we do doesn't work perfectly, every now and then Congress gets one right, and I think that Support Act was one of those. I yield back. Thank you.